Food Technology from the University of Jordan. She started her career as a freelance dietitian, then joined to UNRWA in 2011. And she works there now, and she works mostly on nutrition aspects of obesity, non-communicable disease, and school health issues. So,
thank you very much. Thank you for the intro. Good morning, everyone. Thank you so much, RESCAP, for inviting me to present my campaign, our UNRWA awareness campaign. So today I will talk about the outcomes of campaigns for Palestinian refugees with diabetes attending UNRWA health centers. Okay. I'm not good with technology. So, for those who doesn't know UNRWA is the United Nations Relief and Work Agency for Palestinian refugees in the Near East. It began operation in 1950, serves 5 million Palestinian refugees, Jordan, West Bank, Lebanon, Gaza Strip, and Syria. UNRWA provides 3 main services, which is health, school, education, with 700 schools, relief and social services, mainly women program centers and rehabilitation centers. For health services, there are 139 primary health centers across the 5 fields, with 100 million budget per year. All services UNRWA are health services UNRWA are free of charge. So, what about NCD program in UNRWA? NCD program has been, as Dr. Yusuf presented in his poster presentation, there is an NCD program in UNRWA health centers, which we have a problem in NCD that is the leading cause of mortality and morbidity among Palestinian refugees. Around 11% of Palestinian, the population above 40 years are diabetic. So based on this fact, UNRWA, with support of World Diabetes Foundation, conducted a clinical audit on 2012. So I'm going to just say the major clinical audits, and Dr. Yusuf presented this poster about the whole methodology on clinical audit and the findings of clinical audit. So one of the major, there was various issues in diabetes management and prevention. Over 90% of diabetic patients were obese or overweight. It's shocking, very shocking. 64% of them were obese. If you go to our health centers, if you enter any health center in UNRWA, you'll find like huge audience. Let's say more than 50% of them are, you can tell, without calculating any BMI, you can tell they are obese or overweight. So we have a huge problem. UNRWA, based on these facts, embarked a new campaign to assess diabetic patients to change their lifestyle. So the main campaign, the main idea of the campaign to be fun, interactive, as well as not very boring posters, leaflets, and such like that. So let's talk more about the campaign. We had a slogan, of course, after brainstorming with the fields and health staff, about to have a slogan for the campaign. So it was "Life is sweet with less sugar." In Arabic, "الحياة أكثر سعادة بدون سكر زيادة." The main objectives to the campaign was to build the medical staff capacity for diabetes care, and also to increase awareness and health education about diabetes care through conducting group awareness sessions and change the attitude and behavior to a healthy, as much as possible, to a healthy lifestyle. So it was a group sessions, okay, and it was more or less fun. Group sessions, more interactive sessions. Also conducting outreach screening. In UNRWA, we do passive screening. The patient comes and we screen them if they have any risk factors. So this one was conducting outreach screening. We go out of the health center and for screening activities in the community targeting high-risk population. So I'm going to start with the diabetes campaign time frame. Phase 1 was planning preparation. There were pre-planning campaign meeting with the field, with the health centers. Also, partnership with NGOs was very critical. We had a great partnership with local NGOs and local communities in a high-member camp community. And also, advanced training was conducted on comprehensive diabetes care and availability of budget. So every health center has a certain budget to conduct the activity. Phase 2 was launching the campaign and implementing the activity for 6 months. So we started in April 2013 and finished in October 2013. Phase 3 was evaluation and data collection. Inclusion criteria: the 8 largest health centers, based on clinical audit, have been included in the campaign. In 4th field, of course, Syria, for the obvious reason, it wasn't included. So we selected patients that have DM or DM with hypertension for more than 1 year, and they should be attending our health centers. And most importantly, they should have willing to participate. They want to participate, they want to change, and they want to improve their control status. What was the main activities for the campaign? Mainly was 3 main activities. Education sessions about diabetes care management. Okay, can you hear me?
Yeah.
Okay. And there were healthy cooking group sessions as well. So a lot of healthy group cooking sessions, traditional healthy recipes, and a group exercise session on weekly and monthly basis. What measurements were taken? Part of the anthropometric measurements: waist circumference, weight, and height. And for biomarkers, 2 hours postprandial glucose test, and cholesterol blood pressure. Also, most importantly, the percentage of attendance were tracked on monthly basis. And there were pre and post questionnaires for every participant were also collected. I'm going to go present some of the results, not all of them. So maybe we started with 1,300 participants with DM and DM or hypertension from the 8 largest health centers in the field, and finished with 1,173 participants. So we started with 1,300 and finished with 1,173. 95% was female and 223 were male, with a major age group between 40 to around 60 years. Our surprise was the attendance. It was really surprising for us because, to be honest, we thought if 40% to 50% of them just attended and finished half the campaign or 6 months of the campaign, the whole campaign, that would be great. But the percentage of attendance was, for example, in Gaza, over 95% of the percentage of attendance was over 90%. In Jordan, it was over around 85%. In Lebanon, over 71%. And in West Bank, over 75%. So percentage of attendance for us, relatively speaking, was pretty good. About weight reduction, 33% of them have lost up to 3% of their weight, and 60% of them have lost 5% of their weight. BMI before and after for obese, 73% were obese before the campaign and 69% after the campaign. For overweight, it was 22% obese, overweight, and after the campaign, it raised to 25% overweight. So we think that who were obese, those who were obese become overweight. This is all.
Another 5 minutes more.
Okay. For waist circumference, according to WHO category, it was significant change before and after for males for high-risk groups, and also for females for high-risk groups above 88 cm, and males 102 cm, significant change before and after. For the biomarkers before and after, there was improvement in the PPGT, cholesterol, blood pressure as well. But we had a question, so what are the effects of the interventions on the measurements? So we found that weight reduction, education and cooking had significant effect after, of course, adjusting the confounders of sex, age, smoking, control, and abuse. Education cooking had significant effect of weight reduction. 3 sessions had significant on BMI, but for waist circumference, only education has significant effect. And for cholesterol, only exercise and PPGT, education and cooking have significant effect. I said before there were pre and post questionnaires. Based on questionnaire feedback, a significant change in the patient's cooking practices were observed. For example, we asked how do you add oil to how do you add oil to the recipes? Is it estimating or measuring? So they shifted the significant shift between estimating and measuring, or estimating pouring the oil, or measuring how much they add oil, and also shifting from using ghee to plant oil. Also, an significant increase in number of meals, so more small and frequent meals were consumed. Our conclusion: the campaign proved to help patients improve their knowledge about diabetes, adapting healthy lifestyle. It also improved the waist circumference, blood glucose due to the various sessions and varieties of sessions. It enabled the health staff to improve knowledge and counsel skills in the management of diabetic patients. And also, I think it really improved the partnership with local NGOs and the community as well. So we think that such campaigns need to be sustained. So it's a challenge to be honest for us for the sustainability of the results and sustainability of the campaign. So there are sustainable plans, and also the expanding to the other health centers to more. Now we are in the second round campaign, and it will finish. It started after Ramadan, and now it will finish in February. And we also recommend to strengthen more the partnership with local NGOs and local communities. I'll leave you with a few of the pictures. For example, we did, every field has specific launching activity for the campaign. There were cook show with Community in General, the ex-Community in General, and UNRWA TV, and it was broadcasted. They did healthy maqluba recipe. And also with 2 famous local actors in Jordan, they did an entertainment fun play with the key messages given to the refugees in 10 camps in Jordan. These are cooking sessions. This one, the first one, in Gaza, 2 men are helping during the cooking session. These are in Lebanon, and this is in Jordan. Some of the exercise sessions, the first one in Gaza. So there's a lot of volunteer sport instructors, nutritionists that newly graduated. They volunteered in the campaign in the 8 largest health centers across the 4 fields, and also at school, UNRWA participated, the Women Program Center participated. I have to say the last one in Hebrew. This staff nurse, she had a good relation with a private gym, okay, to let for free for 6 months for this group, for female and male, of course, different hours, to go and exercise for free. They just have to their name in codes, specific codes, and that's it. And after the campaign for sustainability, they give them, like, if they pay really small, or even they started, if they can't, it's for free, just go. And people were really, really impressed and happy about it. This is in Lebanon, this is in Jordan, and this is part of the education session. Thank you so much.
You want to take some questions?
Okay.
Thank you for your presentation. I would like to ask if you have information about the people who were unwilling to change, because you include people who were willing to change or willing to participate.
Yeah.
So do you have any information, numbers, and characteristics of people or patients who were unwilling to change?
Unwilling?
Unwilling, because you're talking, the inclusion criteria was willing to change and willing to participate. But do you have other proof? Thank you.
Dr.
Thank you very much. I do agree that any intervention program is going to have a good difference in the results, directly after pre-post. But this difference, we need to maintain it. I mean, the intervention itself is not the issue. The issue is to maintain the intervention. This is so, and I think that the short-term effect will appear directly of the intervention. But we need the maintenance phase to be the same for a long time to change the behavior of the people to be a long-term behavior towards these issues. Thank you very much.
My answer is for both. No, for both. For we actually, these points are raised with the field that we discuss a lot, the sustainability plan, and also here for people that really not interested or they are in denial, whatever. So we thought how to expand and also how to sustain, and how to sustain the key messages and how to sustain behavior, whatever, so etc. We developed a package for the health staff that they have a scientific hour every week, and they have to conduct education session, but it's not very strict. So we developed some kind of package, a flip charts that give them, it's easy that it's a picture, because most of our patients are illiterate. They cannot read or write. So it's pictures, and for the health staff, it's messages standardized across the field, and messages here. So they conduct on weekly basis. They just give 2-3 messages for all audience because they have a lot of them waiting area. And also for the sustainability plan, there are follow-up, intensive follow-up. It's not easy. I'm not saying it's easy. Our biggest challenge is sustainability plan, as I mentioned. And it's on monthly basis, and some fields in 3-month basis. They have to call the patient and come and just let's gather again, and who have a success story, let's just discuss your success story. And also with education sessions, education materials such as we did a plate for them, so to encourage them that we give them as well as insulin injection too, because there is problem in how to inject themselves with insulin. Also sessions on foot care with a kit, hygiene kit and also we gave them a pill box that how to arrange your pills and medication. And you understand the pill, I don't have it now, but the pill box have the sun
without the question.
Yeah.
Hindiya and then Rima Afifi, and that would be all.
It's just a comment that your intervention is very interesting. And we in MOH are, as Nadeem said, yesterday, we apply the PIN protocol, which has a certain, very important component, which is the nutritionists, and they are unavailable in Salfield. And the campaign that you do is very interesting. And another thing which is very good to be in the primary healthcare centers is a dietitian who has consultation, has the all consultation to go to the diabetes patients and the chronic diseases patients to them, because usually the nurses doesn't have those actually the dietitian informations or detailed information that we should give to the patients.
That's why they were.
Good morning. First, I want to say thank you for the presentation. It was very nice. And I think that, we commend anyone that's doing interventions and doing evaluations, because I think that's a first start. So behavior change interventions, as we know, are very difficult to both implement and evaluate. And so as long as we are doing something and evaluating it, and something that goes beyond just providing information, which is what people mostly do, I think it's excellent. And what we learn from it is actually then what helps us to improve. So excellent job. My question that doesn't need an answer right now is just how you measure attendance, because it could be 90% for at least come once, or it could be 90% for every time. So I don't need an answer now, but I think it's just important to clarify percent attendance, how you measure that. That's all.
One second, happy with it.
For the attendance, it was on monthly basis. For the attendance, it was on hard copy first, the staff nurse take it, and then she filled up there with a master sheet. We have a lot of details. I can share with you. We have a master sheet on every session, every month, every week. So it's a big sheet that they really did a great job. It's not easy. We presented it this way, but on the ground, my colleagues can say it wasn't easy.
Thank you very much. We'll take it at the end.
Okay.
Thank you.